Hello, today's discussion will be on mitral stenosis, one of the rheumatic heart disease in children. As we say, in rheumatic fever, it licks the joints and bites the heart. This means the joint and the heart involvement are two most common presentation in rheumatic fever, where there is no sequelae in the joint, but in the heart it leaves a sequelae as a rheumatic heart disease which requires a lifelong treatment. In mitral stenosis, is less common in case of children. Only 10% cases of mitral stenosis are seen in children, cause being rheumatic fever, where in women it is 4 times more common than men. Other causes are congenital and may be associated with rheumatoid arthritis or systemic lupus erythematosus. In mitral stenosis, there is narrowing of the opening of the mitral valve between the left ventricle and left atrium. So blood cannot flow from the left atrium to left ventricle very freely. Come to the hemodynamics. Obstruction to the flow of blood across the mitral valve during the left ventricular diastole is occurring. So left atrial pressure increases, leading to hypertrophy of the left atrium. As all of us know, there is no valve between the left atrium and the pulmonary vein. Blood is easily passing from the left atrium now to the pulmonary veins, leading to increase in the pulmonary venous pressure. Pulmonary congestion occurs and dyspnea occurs. That is the commonest symptom occurring in mitral stenosis. After this, the pulmonary artery pressure also increases. That means pressure on the right ventricle is going to increase, leading to concentric hypertrophy of the right ventricle without increase in the size of the right ventricular chamber. So ultimately, though the pressure is increased, heart size remains normal in mitral stenosis. This is just a flow diagram I am showing of the same hemodynamics. First, obstruction of the flow of blood occurs across the mitral valve. So obstruction to left atrial emptying occurs. This leads to decreased left ventricular filling, and then here there is increased left atrial pressure, which is going to increase the left atrial size, and ultimately high risk for atrial fibrillation occurs. And here, with the increased left atrial pressure, there is increased pulmonary venous pressure, pulmonary venous congestion occurs, and then pulmonary edema, heart failure can occur. And this is going to lead to increase in the pulmonary artery pressure also. So right ventricular overload is occurring and right ventricular concentric hypertrophy occurs. With a mild to moderate mitral stenosis, forward flow across the mitral valve remains normal, but with the severe mitral stenosis, forward flow is diminished, so cardiac output decreases, giving rise to small volume pulse, and the extremities are cold. That is another clinical feature. The child remains asymptomatic until the stenosis is approximately 2 cm square. The normal diameter of the mitral valve orifice is 4 to 5 cm square in diastole, and then it may reduce to as small as less than 1 cm square in severe mitral stenosis. So they remain asymptomatic till approximately 2 cm square diameter. After that, they may show symptoms. So in this way, they may remain asymptomatic for approximately 20 years. The presentation of mitral stenosis can be after second decade only. So in the children age group, many times we do not see mitral stenosis. The presenting symptoms, 50% cases present with the congestive heart failure, and then others may show with the atrial fibrillation. Dyspnea is one of the prominent symptoms which progressively increases with the physical exertion, fever, emotional stress, anemia, atrial fibrillation. Other symptoms are cough, pulmonary congestion giving rise to rales, there is palpitations, fatigue, hemoptysis due to acute pulmonary edema, and features of right ventricular failure can be present, which are edema, hepatomegaly, and then raised JVP. Mitral phases can be seen. This is due to malar flush. This is due to cutaneous vasoconstriction. There is a malar flush around the both cheeks and the bridge of the nose, like a butterfly rash, and then you get a small volume. On auscultation of the precordium, examination of precordium, apex is tapping apex, apical diastolic thrill is present, left parasternal heave is present, S1 is accentuated, that is first heart sound, and second heart sound, there is a palpable second heart sound is palpable at the second left intercostal space. It is normally split and P2 is loud. P2 component is loud. Opening snap is present. And the murmur you hear in the mitral stenosis is the typical low-pitched, rough, rumbling mid-diastolic murmur with a pre-systolic accentuation, and it is best heard over the apex with the bell of the stethoscope in a left lateral position and in expiration. Ejection systolic murmur over the pulmonary area can be heard if there is a pulmonary artery hypertension. Now come to investigations. X-ray chest, the heart size is normal and you see the features of pulmonary venous congestion. Other features in the X-ray of mitral stenosis is straightening of the left atrial appendage along the left heart border. So along the left heart border you can see straightening of this border, and then double density sign you can see on the right side, that is right side there is due to left atrial enlargement, it pushes into the adjacent lung and creates an additional contour superimposed over the right heart border. So you can see a double density or double right heart border. It looks like a double right heart border. And if you take a barium swallow X-ray, you can see left main principal bronchus being a bit elevated, that is due to compression by the left atrium which is enlarged. And Carly B line is seen. These arrows are showing Carly B line. They are horizontal lines in the lung at the periphery that extend to the pleural surface. It denotes thickened edematous interlobular septa, which is due to pulmonary edema, which occurs in the mitral stenosis. Other investigations you do is ECG shows right axis deviation, right ventricular hypertrophy with the P mitrale. Echocardiography shows left atrial enlargement and pulmonary artery hypertension, and thickened immobile cusps can also be visible. Cardiac catheterization shows a pressure gradient between the left atrium and the left ventricle. Now come to management. First of all, heart failure should be managed with the diuretics and digoxin. Anticoagulant therapy if atrial fibrillation occurs. And rheumatic fever prophylaxis is given with the penicillin that should be continued 10 years or till 40 years, whichever is longer, and sometimes maybe lifelong. And then infective endocarditis prophylaxis according to indications. Then finally, treatment is surgical, mitral valve surgery. Closed mitral valvotomy can be done, or commissurotomy is done, or open mitral valvotomy can be done. Percutaneous balloon valvuloplasty is another option, and mitral valve replacement finally with the open heart surgery. Complications. Hemoptysis is one of the complications which is due to acute left ventricular failure, due to severe pulmonary congestion and edema, due to recurrent bronchitis or pulmonary infarction it can occur. Atrial fibrillation occurs in 2/3 of cases. Atrial fibrillation precipitates heart failure and thromboembolic phenomenon. So you can get all the features of thromboembolism in different organs, and pulmonary hypertension can occur. Sudden cardiac death is another complication that occurs due to arrhythmias, and then infective endocarditis is another complication. Thank you. We'll come again with the next topic.